Good afternoon, everyone. Firstly, I would like to thank the organizing committee for giving me this opportunity. Today, I would like to show you this research that started during COVID pandemic and raised from the necessity to face off the COVID-related acute respiratory distress syndrome. During the pandemic, many of the most severe COVID-19 pneumonia progressed into a condition that closely matched to the definition of the acute respiratory distress syndrome, that is characterized by the extensive inflammation and extensive fibrin deposition that contribute to Yali member formation and thus reducing the oxidation. And the dysregulated fibrinolysis is a hallmark for this syndrome. In this sense, to recover the lung function and targeting the fibrin clot, we propose the plasminogen as a treatment for multiple reasons. The main reason is that plasminogen is the precursor of plasmin, that is our physiological enzyme responsible for the degradation of the fibrin clot. The second reason is that it has an immunomodulatory action, so it can reduce the inflammation. And finally, it is available as an orphan medicinal product from Cadium Biopharma, and thus could allow to a fast translation for clinical application. So the primary objective of the work was the repurposing of PLG-OMP as an available treatment for the acute respiratory distress syndrome. So we nebulized the PLG in airflow by using an hydrogen solo mesh nebulizer. So we check the protein stability, aerosol performance, enzymatic and fibrinolytic activity, and then we use in vitro cell models to check the immunomodulatory activity and biopharmaceutical properties. And in the end, we check the efficacy in vivo models. Only on concomitant administration of oxygen therapy, we observe a loss of activity. So the secondary objective was to create a stable formulation by the addition of the hydroxypropyl beta-cyclodextrin that required a minimal handling suitable for hospital pharmacy protocol. Today, for time reason, I will not go through the complexation studies, but I will focus only on the effectiveness of this complex. So firstly, we check the aerosol feasibility, and we can see that 98% of PLG remain in the monomeric form after nebulization, and non-aggregation were detected by using SDS-PAGE and DLS. The aerosol performance were assessed by using a next-generation impactor coupled with a breathing simulator, where we put different breathing profile, from the LT adult profile to the simulated pathological profile, from mild to severe acute respiratory distress syndrome. And as you can see from the result, from the fine particle fraction and the aerodynamic distribution, this is not drastically affected by the pathological profile, confirming the suitability for the administration. Patients with this syndrome require a high concentration of oxygen to maintain sufficient oxygenation. So we perform the nebulization in airflow and oxygen flow. And as you can see from the graph, in airflow, we have the maintenance of the activity, while for the oxygen flow, we can notice a loss of activity. So we think to have the hydroxypropyl beta-cyclodextrin, and we check the enzymatic activity by using a fluorogenic substrate. And as you can see from the graph, we obtain the maintenance of the enzymatic activity by the addition of the hydroxypropyl beta-cyclodextrin. To check the immunomodulatory activity, we perform an in vitro inflammatory cell model consisting of LPS-activated macrophages, and after the establishment of simulated inflammation, we treat the cells with PLG and PLG nebulized. And then we check the pro-inflammatory cytokines level. As you can see from the graph, we obtain a significantly decrease of the pro-inflammatory cytokines for both PLG and nebulized PLG. So this could be a great result because nebulized PLG could reverse the effect of LPS activation. The fibrinolytic activity was evaluated directly on a human fibrin clot, both by the observation of the clot dissolution and by measuring the dimer formation, because the dimer is one of the main fibrin degradation product. The assays were performed on the untreated PLG-OMP and the complex and the nebulized sample, either nebulized in air or oxygen. We used two different models. The first one by using an external administration of urokinase to trigger the PLG activation. And then the second one without the external activation, but by using the inflammatory cell in vitro cell model, where the PLG is activated by the factor released by the inflamed cells. And as you can see from the graph, we obtained the same trend for both models. And for PLG nebulized in airflow, we maintained the fibrinolytic activity. And for the nebulized in oxygen flow, with the addition of the beta-cyclodextrin, we have the maintenance of this activity. Then we investigated some of the biopharmaceutical properties of the nebulized PLG-OMP. And we can say that about 20% could diffuse through simulated mucus within 5 hours. The cell viability assays were performed on NCI H441 lung epithelial cell line by using a WST1 cell viability assay. And we can say that for PLG and for the complex, we obtain a good biocompatibility. Then we check the permeation across an ELI model, so an air-liquid interface monolayer, and only 0.08% of the PLG-OMP could permeate through the monolayer. And this supports the local lung action with limited systemic exposure. In the end, the in vivo efficacy of PLG-OMP was assessed by using a murine LPS-induced acute respiratory distress syndrome. And for the in vivo studies, we used two different models to simulate two different stages of this syndrome. So the first one, that is the short-term model, 24 hours, was used to simulate the acute phase of the syndrome. And we checked the pro-inflammatory cytokines level in the lung homogeneity. The second one, that is the long-term model, for 14 days, was used to simulate the subchronic phase of this syndrome, and we checked the histology and the fibrin deposition in the lungs. As you can see from the micrograph on the left, we can see a decrease in the hyaline membrane formation and fibrin deposition. And from the graph, you can see a decrease of the pro-inflammatory markers in the lung homogeneity. So in conclusion, regarding the repurposing of PLG-OMP, the study was effective up to the in vivo studies when nebulized in air condition. With respect to the co-administration of the oxygen therapy, hydroxypropyl beta-cyclodextrin clearly preserved the PLG activity. But obviously, additional in vivo studies will be required to validate the stabilized formulation. So the take-home message is that inhaled plasminogen, especially when stabilized with the cyclodextrin, offer a promising dual-action therapy for the ARDS, successfully targeting fibrinolysis and inflammation with efficient pulmonary delivery. I want to thank the funding and the collaborators from University of Pisa, Hospital of Livorno, and Cadrio Biopharma, obviously my research group from University of Pisa, and all of you for your kind attention.
Thank you, Lucia. I have a question for you. So you said that you use hydroxypropyl beta-cyclodextrin as excipient. Can you explain why you choose this excipient?
Thank you for your question. Cyclodextrin are cycle oligosaccharide that are capable of creating an inclusion complex that could be useful for labeled drugs like proteins. And also EMA guidelines recommend the safety use for about the 10%, and we use the 5% of cyclodextrin, and most recently they are even more used for also for the lung delivery.
Thank you.
Thank you.
Is there any question?
Okay, thank you very much for your presentation. My name is Bernhard. I come from Vienna, which is very close to Italy, I hope so. I was very interested in your presentation by two reasons. First, I worked for 10 years with Plasminogen and also for the recombinant development in different pharmaceutical companies. Second, for the last 20 years, I'm active in the area of ARDS. I have conducted in total 3 different clinical trials in ARDS patients in Europe, different hospitals, including Italy. And ARDS is characterized as an acute onset with having water in the lung all over the place. And so the patients would need extra oxygen, as you explained. And the fibrinolytic process takes place later, after the acute phase of, let's say, 7 days.
Yes.
Did you think about any clinical outcome, primary outcome, if you would perform a clinical study, how to measure the effectiveness of recombinant plasminogen inhalation? What would be your clinical hallmark to achieve with these patients?
Firstly, I think the recovery of the self-respiratory capabilities. So the problem is that the fibrin clot and the formation of the Yalin-Remmer prevent the gas exchange. So the patient could breathe autonomously. So I think the first symptom is that the patient could breathe without any support or oxygen flow.
Okay, this is fine. I would suggest eventually we think about quality of life. Okay. So patients have to survive, let's say, at least the first 28 days after they developed ARDS symptoms.
Okay.
And then you should start a therapy to get some strength back to the lung tissue with some kind of new therapy. And this would impact the quality of life of these patients, because we all do know that ARDS patients suffer lifelong from loss of lung function. And quality of life is some established measurement also by the regulatory agencies, in addition to mortality or duration of mechanical ventilation, which cannot be modified with your plasminogen. But quality of life of patients who survived ARDS could be a very good model for you in future.
Thank you so much. Thank you.
Thank you.
Thank you for the nice presentation. I have a question about your method to check aggregation after nebulization. So you said you use SDS page.
Yes.
But actually the SDS will deaggregate. If you have aggregate, the SDS will dissociate the aggregates. So to check for insoluble aggregates is better to centrifuge and check concentration before and after centrifugation, and also to check for soluble aggregates is better to do site exclusion chromatography. So I was wondering whether you have done this.
Thank you for your point. No, yes, we use HPLC for the quantification of the plasminogen, but we didn't check for the soluble aggregates yet. So thank you for this suggestion.
Is there any other question?
I have a question for you, also regarding the cyclodextrin you use, because I think you showed that you have a slightly, let's say, sustained release out of your particles. Is that, and I guess this is due to the excipient probably, is that something which is actually beneficial in the overall treatment? So is that by intention, or does it just come with the excipient?
I think the latter one. Yeah. Thank you.
Okay. Thank you, Lucia.
Thank you.